We are back from ASRM, the 75th year. It's kind of hard to believe, right?
That is.
75 years. So
I feel like I've been here for 75 years.
I'm Alice Crisci, co-founder and CEO of MedAnswers and the FertilityAnswers app. And I'm here actually with an old friend and colleague of mine that I haven't seen in years, Marlane Angle, who is a PhD, and she runs an incredible lab up in the San Francisco Bay Area. First, let's talk about your clinic.
Mm-hmm.
What's the name of your clinic? Where is it located specifically so everybody knows how to connect with you?
My home clinic, so right now I direct 5 labs, but the one I have been at for over 10 years is Laurel Fertility Care in San Francisco. It's on California, and we have 2 docs that are there now, Colin Smichael and Geraldine Ekbo.
And I have personally visited their clinic in the past. That's where we met, and I have to say I love it. You'll find incredible care, very personalized care in this practice.
Nice people.
Very nice people. What we want to talk about today is one of the probably most widely discussed topics on Facebook message groups, and we get asked these questions a lot on the FertilityAnswers app, and that are numbers. So the topic today is attrition and how 1 egg does not equal 1 baby. And we know heading into IVF, it's an incredibly emotionally charged time. We know how difficult that is, and the numbers game makes it even more difficult.
And that's exactly what I call it. It's a numbers game.
So let's start with the basics. Somebody retrieves 15 eggs. What can they expect to happen over the course of retrieval, fertilization? Go through the steps for us.
Well, I think we need to take it back even one step further than that, is that when a patient's going through a stimulation cycle, they see all of these follicles develop. So often they assume that where there's a follicle, there's an egg, and that's unfortunately not always the case. So if a patient comes in with 15 follicles, the first question we have to ask is how big are the follicles? Because we don't necessarily expect to get an egg out of small, say 10, 11, 12 millimeter follicles. So we expect to get, theoretically, an egg out of every follicle that's bigger than 15 millimeters, but
how big is
it can go down to 12.
Oh,
well,
so that big, okay.
15 to 18 millimeters.
Small. It's small.
It is. So 15 is 1.8 centimeters, and there's 2.45 centimeters to an inch. So it might be even more like that.
Wow.
Half an inch.
Half an inch. Okay.
Yeah, up to, but we'll see follicles that get as big as 20. So that'll be almost an inch. Why you feel horrible.
Your body go like that, and you look like 3 months pregnant as you're activating all those follicles in the hopes that, and you can still, so when that does happen and people are seeing, let's say that they see 7 that are growing and they're growing to the right size, there's still a drop-off from the retrieval.
Because we can't see the eggs. We can see the follicle, which is like it's like taking a picture from an airplane. You can see the houses down below you in a town, but you can't see how many people live in a house. So theoretically, theoretically you have 1 person per house, 1 egg per follicle, but we can't see it. So when we try to get it, when the physician tries to get it, sometimes they do and sometimes they don't. So generally, we think that those big follicles are coming in with very loose attachments between the egg and the wall of the follicle. So we think it's going to happen. We think we should get an egg out of every follicle, but I tell patients it can go anywhere from 50% to 100%.
Wow.
So,
and then you have the issue, though, of some of them are mature and some of them are immature.
So that's the next drop-off.
Okay.
Let's say we were lucky, make math easy, we got 10 eggs out of those 15 follicles. Then we expect about 80 to 90% of those are going to be mature. So 8 or 9 out of the 10 that we retrieved. And maturity is defined by the presence or absence of a structure called a polar body. And we don't know that until we clean the egg, which is later in the day. So usually by the time a patient leaves the center, they know how many eggs we've gotten, but they don't know how many were mature. So that's something we find out later in the day. If we're doing ICSI, we will put a sperm in with every one of those eggs that was mature. We don't put sperm in with immature eggs, and there can be two kinds of immaturity. So we may have what's called an M1. So it looks like it's starting to develop. It's lost the characteristic of an immature egg, which is the presence of a germinal vesicle, but it hasn't developed the characteristic of a mature egg. So you can have immature, intermediate, mature eggs, germinal vesicle, M1, M2, that's what we call them. So our expectation is 80 to 90% of the eggs that come out of the ovary will be an M2 egg. So we'll inject everything that's an M2, but then everything we inject doesn't fertilize. So a reasonable fertilization rate with ICSI should be, these days, it should be in the neighborhood of 70 to 80%.
So we already started with, so if you injected 8.
Yes, if we injected 8, now we're down to 75 to 80%, so 6, maybe 7.
6 or 7, okay.
Of those are going to fertilize, and then not every one of the fertilized eggs is going to make it to that next stage that most of us are transferring at these days, which is called the blastocyst stage. Right. So we expect about half of what fertilizes will make a blastocyst. So if you've got 6 or 7 that are fertilized, if you're really lucky and all the stars are aligned and your eggs are perfect, you should get 3.
This is making me emotional.
It does.
It is so incredibly stressful, and I'm just sitting thinking, when I was going through it, but I'm thinking how lucky I was hearing your numbers. Yes. So, you know, I always say I actually feel really grateful that I got my cancer diagnosis at the age of 31, because I retrieved 31-year-old eggs.
Exactly.
I will forever be grateful about that.
Sorry. Did you do the retrieval before you started your treatment?
Yes, I did.
See, that's another thing that makes you really lucky.
Yes. I didn't do surgery. Yeah. I didn't do chemo. I didn't do anything. I said, and my surgeon actually pushed back on me. She said, I think you're too overwhelmed. You should wait till after surgery. I said, I'm not waiting for anything. Right. And then thankfully I didn't wait, because I called a clinic on a Friday and they said, well, we only have 1 consult available for you next week on Tuesday at 5 p.m.
I'll take it.
I said, I'll take it. And I put down a hefty credit card fee on it. And then she said, well, you're already on day 2 of your period. I got to start your stims tomorrow.
Done.
I said, I'll be there, 7 a.m. Yep. You know, and then by 10 a.m. I had a sperm donor catalog in my hand. Yep. You know, so the craziness. But I was so fortunate. Now, granted, I was on the cusp maybe of potentially hyperstimming. I did retrieve 31 eggs, which was a lot. Yeah. 26 were M2s. 26 were mature.
That's good, though.
And
that's almost right on that 80% number.
Mm-hmm. So I split the cycle, and I fertilized 14 of them with donor sperm at that moment, because back then egg freezing was experimental. Right. We weren't doing vitrification yet. Right. I mean, this is like, it feels like forever ago. And then I have, it was just yesterday. And then I have, I think I have 11 unfertilized eggs still that are frozen. So maybe I probably had 25 that were mature, not 26. And so I have a cohort then to go into of 25. Now, when I decided to have my child, they said, do you want to, thaw the eggs and use a different donor source? And I have a vial of sperm lactura. I said, no way. I want to go with you told me I only have a 3% chance of those eggs working. Yeah. It's changed now. It's much, much better. But it's still relatively unproven, because there's not enough people who have gone back to use their fertilized eggs. Right. Right. And the embryos have been so tried and true. And so when I decided to have my son, I said, no, let's thaw the embryos. So mine went from 14, and then 9 made it to the thaw. So I had a pretty big drop off from the thaw too. So you froze, wait a minute, you started with 14 frozen day 2s. Day 2s, okay. Day 2, yes. Frozen embryos, because they were freezing at day 2 then. Yeah. And then we thawed them, and then the ones that were biopsyable were 9. Okay, so that's good. That was good. That's very good. That's what I mean. I'm listening to you emotional, because I feel so lucky that I had such a large cohort. Yep. And so what happened was, of the 9, then I had 2 that came back trisomy. So then I had 7 to work with. And then I had 2 that they recommended transferring. One was a fully hatched embryo girl. All the rest were boys. So I transferred the girl and the boy, and I have the most gorgeous son that came out of it. Yes. So I feel so lucky that my success story, I beat the odds. Yeah. but I did start with
All.
31 eggs.
Yeah.
And you know, I keep seeing people wait too long to get into the clinic. So they're already working with older eggs where had they gotten in 2 or 3 years prior, they could have had a larger cohort. You know, what is your thought on, you know, doing a couple of egg retrievals first before then a frozen embryo transfer, again, to get those younger eggs?
Absolutely.
The sooner we get the younger eggs.
Yeah, and we can store embryos indefinitely.
Right.
So it really makes, I don't know that it makes sense, except, well, I think it makes sense from the standpoint of money.
Yeah.
You know, if you don't have endless amounts of money, then you may want to try to push it through so you can say, all right, I did my retrieval, I know I've got 4 embryos in storage. Let's go ahead. These days in many of my programs we transfer one, especially if we've done PGS testing on it, or PGTA testing. We know whether they're male or female. We know if they're euploid or not euploid, which means either a normal, chromosomally normal or abnormal. So we're down to, in most cases, a transfer of one. So a lot of times, you know, if the patient gets to the end and says, all right, out of those 6 that we might have had make blastocysts, or 3, whatever, I don't remember the number as we calculate, it was probably 3. Some of them are going to be aneuploid, so some of them are going to be normal. So let's say you get really lucky and you have 2 embryos, so you've got 2 attempts.
Right.
So you may, these days with pregnancy rates are running about 60%. So you may feel like you have 2 attempts.
Than a natural or unassisted attempt. It's much higher.
Much higher.
So I think, you know, advocating for people to do a single embryo transfer with a pristine uterine environment in a frozen embryo transfer situation, right?
Yes.
And then you have that second attempt sort of, you know, if it doesn't work, you've learned maybe, you know, if you need to adjust medications or so forth.
Timing of the medications.
Timing.
Maybe transfer a little later so you can use do the ERA.
Exactly.
It's gotten so much better
Right.
than, you know, even 7 years ago or 8 years ago when you did the transfer. And how long before that when you did your free
5 years. So I did my free cycle 5
years
years.
ago.
Yeah, 12 years ago just about. And it's
Things
kind
have
of
changed
so much.
massively.
And heading into my next transfer next year, it'll be my first time that I've ever done a single embryo transfer. And I'll go one at a time this time.
Well, the thing we're finding is that if you don't transfer in a fresh cycle, if you wait, then most people are finding their pregnancy rates are better because a retrieval cycle stimulates the ovary. We're focused on the ovary, getting those eggs, getting those embryos. We're not focused on the uterus.
Exactly.
So with an FET cycle, you ignore the ovary. You don't care what's going on in the ovary. You just want that nice, lush, healthy endometrium.
You want that little embryo to burrow and get nice and cozy.
So if you know you have one euploid of whatever sex, then you probably are running anywhere from 50 to 70% chance of getting pregnant in an FET cycle.
Still very high.
Yeah, things have changed. You know, when I first started, patients had a 10% chance of getting pregnant back in the 80s.
Wow.
So I look at where we are today versus 10%. And I think how did anyone manage to convince themselves that 10% was a reasonable thing to attempt?
Because it was better than 0.
It was better than 0.
Right?
And like I heard many patients say to me, somebody has to be that 10%. I can be that 10%.
That's right. I think people still do the same thing, right? I mean, even though we know 2/3 of cycles are still failing the first time, we still know that. But still, as a patient, when you're the patient, you say, but I could be the third that isn't a failure the first time.
And I think that's important. I think everybody has to come into this with hope that this will work for them. And, you know, for most of us on the lab side, we hope the same thing. You know, if we had our way, 100% of our patients would get pregnant. We don't want anybody to not get pregnant. And we do everything we can to make sure that it's the best cycle possible for every person. But sometimes we can only work with what we get.
So here's a question for you about the lab and the quality of labs. With this attrition, how much is nature to blame? How much is the lab quality to blame?
That's a hard question to answer. So the thing that I tell patients when they ask me is, I can take a silk purse and turn it into a sow's ear, but I can't take a sow's ear and turn it into a silk purse.
Got it.
So I can take something that comes to me from the physician that is, it's a young egg. It was a nice stimulation. We didn't overstimulate the patient. We didn't take her too late. We didn't take her too early. We've got beautiful looking embryos. And I can mess it up in the lab if we mishandle it. But if I have to get that, 45 or 46 or 52-year-old egg that
Wow.
we don't do the 52-year-olds very often.
I'm thinking, who's got eggs at 52?
No, but we have had patients that are coming through for a second child that got the first one at 49 and said, okay, if I got it at 49, I ought to be able to try again.
Oh my
And it's
gosh.
hard to say no to that based simply on age.
Sure.
I can't say I've ever had a 52-year-old get
sure.
pregnant, but it doesn't mean that there haven't been circumstances we're willing to say, all right, we'll give you one more shot at this.
Yeah.
But still, if we're getting someone who's 48 and they come in with one or maybe two poor quality eggs to start with, we try to take them to blastocyst, they don't make it. I mean, that's just it's disastrous for everybody.
Yeah.
So if we could start with young women, healthy eggs, be gentle on their stimulations, then we should have a pretty good chance of getting embryos. So the things we look at in terms of quality in the lab, we spend a lot of time in terms of trying to maintain our temperature, trying to maintain our pH, try to maintain our incubators to make sure they're doing exactly what we want them to, making sure that our people are trained and that they know how to do things well, and we're not just throwing them into the deep end of the pool and saying, swim, baby, swim. We want skilled, professional, well-trained people that are conscientious about making sure that all the quality controls in place, all the QAs in place.
Right.
And that has changed also. Not only have pregnancy rates changed, but the way we approach the lab, because most of us came into the IVF lab, especially those of us that came in the 80s, we came in from a research environment.
Right.
And we didn't do any of this stuff in the research lab. I mean, a little bit of it, but not like we do today. We do QC on that incubator every single day.
Wow.
And QC on our sperm preps every single day. And that's really different than the way it used
not
to
every
be.
lab is doing that. So what are
They
like
should be doing it.
but what are maybe 3 or 4 things that you would say every single lab should be doing, and a patient could even ask while they're picking a clinic? They could ask, does your lab do these things?
Right. Well, one of the first things I think that they should make sure of is that their lab is certified.
Yes.
Either certified by CAP, which is the College of American Pathologists,
Okay.
or certified by Joint Commission.
Okay, Joint
And-
Commission or
or
CAP,
CAP,
certification.
right.
Great first question
Yes,
to ask or
yes.
confirm. Yes.
I also think it's important to find out what kind of essentially certification your doc has.
Yes.
Is your doc board certified?
Right.
Because in the early days, they didn't have to be. Nobody says they have to be. You can still take a non-board certified GYN or a pediatrician. These people can still do this stuff, but
Wow, I didn't even realize
yeah,
that.
there are
okay,
a couple.
So check that they're board certified. They have a FACOG credential in this case.
Yeah.
Yeah, they have a FACOG credential.
That they're
I
a
want to make sure of.
reproductive endocrinology
Yes.
and infertility
Yes.
specialist.
REI.
Yes,
That's
correct.
right.
Those are important.
Those are the top
and then
two.
The
Yeah.
things you start to, I think it's always worth taking time to talk to your lab people. We
I do
don't
too.
always get the chance.
Sure, I
But
agree with that. Yeah.
Talk to your lab people. Just call up and say, I know you're busy, I get it, but I just want a little reassurance
Exactly.
about what you're doing. So most of us are trying to have 2 people verify everything we do.
Right.
So you have 2 people to verify the names on the sperm,
Right.
2 people to verify the names on the egg dishes, 2
Right.
people to verify the name on the embryo transfer dish.
Okay.
multiple people to verify the name of the patient.
Wonderful.
Those are all things that,
yes.
if you're verified by CAP or certified by CAP or Joint Commission, those are all parts of the checklist.
Right.
Those are things we have to prove.
Standard
Yes,
practices
standard of
that
care.
you have to do.
Yes.
So that's great. Making sure you're certified, board certified physician, making sure that the lab is actually following the procedures as designed by CAP certification.
Yep.
That's wonderful.
Yep.
And then talk to the lab. You know, this is something I know that when I got to talk to my embryologist and the embryologist walked me through every step of that checklist, it was so much easier to understand, and that part went really well.
Yep.
So I was really grateful for that, and I'm encouraged to hear that you're encouraging, people to reach out to the lab.
Absolutely.
Because it's not something that I think that is standard. I don't think every IVF clinic is saying, hey, do you want a chance to talk to my lab director or embryologist?
They don't.
Yeah,
But
so we can change the tide on that.
I think it reduces some stress for patients going through
It does.
a cycle if they know who the face is behind the door.
Exactly.
Because many
No, the
cases
hands
were
behind the
anonymous.
door.
Well,
the
yeah,
hands,
that
the
too.
hands who are
The brain
the
behind
brain,
the door.
I know, it's like the hands and the brain, the art behind the art.
Yeah, yeah.
So I agree. I think that that's a wonderful thing. We're running out of time, but I think that this has been so incredibly helpful. In particular, for us to continue to drive home the message, do not delay. If you potentially have an IVF cycle in your future, try to make it happen as fast as possible. These days we're seeing more and more companies cover IVF treatment. That's an option. We're seeing more and more financial aid programs available. We're seeing other financial programs also available, monthly payment plans, things of that nature. I don't want to see people going bankrupt or mortgaging their homes to access treatment.
Absolutely agree.
And we as a company will continue to advocate for better programs so that it's accessible, but it cannot be said enough that the earlier you start, the more successful you will be, the fewer cycles you will need, and the reduced cost overall you're experiencing and having your children can be.
Yes.
Marlane, it was so good to see you again.
Nice to see you, Alice.
And I will come visit you guys soon, hopefully in San Francisco. I would love to see Colin again too. So we're signing off from ASRM, the 75th year, and our Facebook Live. I'm Alice Crisci, co-founder and CEO of MedAnswers. If you have any more questions for us, find us on the Fertility Answers app, download it on iOS or Android, and ask any question that you have anonymously, and we will have one of probably 300 experts at this point answer your question for you. Thank you, and we'll see you soon.